Good evening, students. Welcome to you from Sri Rama Hospital, Jagapet. Yesterday, we learnt about one important topic, that is epithelioma. The epithelioma will be given as a essay question in your theory examination. It may also be given as a short case or a long case in the clinicals. So all diseases which are given as cases in the clinicals are very, very important to you. You must know it thoroughly. So that is why I will give summary to what I said in the previous class. The epithelium arises from squamous cells of the skin and mucous membranes, most commonly at these mucocutaneous junctions like lips. It is the second most common cancer of the skin. The first most common cancer of the skin is basal cell carcinoma. Solar keratosis, that means the parts which are exposed to sun for a very prolonged period. So we'll get a condition called solar keratosis. The solar keratosis, keratoacanthoma, leukoplakia, cutaneous horn, or premalignant lesions of the squamous cell carcinoma, Page's disease, and Bowen's disease are in situ carcinomas. Etiology is due to sun exposure, application of irritants, then the burn scar, chronic ulcers, radiation, human papilloma virus infection. So these are the common causes of the epithelioma. Early lesions may start as plaque, fissure, nodule, or ulcer and grows to form an ulcer with everted margins or as hypertrophic lesion. Biopsy from the edge of the ulcer is diagnostic. So whenever you take the biopsy must be taken only from the edge. From the floor, if you take, most of the times only slough will come. That's why you must focus your attention to the edge. The edge should include the normal epithelium as well as the diseased or the cancerous lesion. Both must be included in the specimen. Then the pathologist will be able to identify and differentiate the normal from the malignant. It is treated by radiation or by surgery. Surgery is by wide excision with 1 to 2 centimeters clear margin. Lymph nodes are removed if they are involved by block dissection. So before removal, you have to confirm it by FNAC. What is block dissection? What do you understand by block dissection? What do you understand by block dissection of lymph nodes? It's radical. Means what? What do you remove? What are the structures that are removed there? Tell me. The main concept of block dissection is removal of the lymph nodes and lymphatics. Can you see the lymphatics? No, you cannot see the lymphatics. Then how can you remove lymphatics if you cannot see them? That is why you remove all the tissues which have the lymphatics. So what are the tissues that have lymphatics? The fascia, the vascular sheaths, the muscles. These are the structures which contain the lymphatic vessels. So you remove the lymph nodes along with fascia, along with muscles, along with fibrofatty tissue that is there in that region. So block dissection means don't consider only block dissection of the neck. Here I just said block dissection. It can be inguinal block dissection. For example, the patient comes to you with a squamous cell carcinoma of the foot. There are enlarged inguinal lymph nodes. FNAC confirms that it is a metastatic deposit is there in the lymph nodes. And what do? You do the block dissection of the inguinal lymph nodes. Then the examiner will ask you, what do you mean by block dissection of inguinal lymph nodes? Then you must tell that you will remove a block of tissue containing deep fascia, fibrofatty tissue, horizontal and vertical group of inguinal lymph nodes, the long saphenous vein, because there will be lymphatics running along the long saphenous vein. So the long saphenous vein. All these things are removed completely. So that is the block dissection of the inguinal region. So block dissection means, just I said block dissection. I didn't mention about block dissection of the neck. If it is neck, you can say internal jugular vein, sternomastoid muscle, etc., etc. But I didn't say like that. I just said block dissection. Okay. 5-year survival rates after surgery or radiotherapy is around 95% for the early lesions. Now, the basal cell carcinoma. It is also called as rodent ulcer. Why is it called rodent ulcer? You must be knowing about the rodents, the rats. They burrow through the earth. So they make big furrows into the earth. Similarly, this ulcer penetrates deep into the tissues, infiltrating into the bones also. That is why it eats the skin just like a rodent eats. Pathology. Incidence is the commonest malignant skin tumor. Age more than 40 years. Gender common in both sexes equally. Race, white-skinned individuals working in tropical countries. Again, here also the exposure to sun is most important factor here. Site of occurrence, 90% of the lesions occur on the face above a line joining the ear lobule to the angle of the mouth. So you draw a line from the angle of the mouth to the ear lobule. So usually 90% of the lesions, they occur above this lesion. Commonest site is inner canthus of the eye, just like this. Rarely on the neck. Etiology, prolonged exposure to sunlight, exposure to arsenical compounds, coal tar, hydrocarbons, radiation. Genetic predisposition can be there. The cell of origin is from basal cells of the epidermis and from the appendages. Thought to originate from pluripotential epithelial cells of epidermis and hair follicles. Spreads locally into deeper tissues like a rodent. It doesn't spread by lymphatics or bloodstream. Clinical features, it may present as a ulcer, nodule, cyst, pigmented lesion, or spreading ulcer. So these are the 5 types of its presentation. It may present like an ulcer. Sometimes it may be just a nodule. That is why it is commonly called as basal cell carcinoma, not as ulcer. If you call it a rodent ulcer, so it looks as if it will manifest like ulcer only. but it can manifest like an ulcer, like an nodule, cyst, like a pigmented lesion, or a spreading ulcer. Site already I told you. Ulcer type. It is a common type of presentation. It usually single, sometimes multiple. It has raised, rolled edges or beaded edges. You can see here, it has a raised, rolled edge. If you look at here, this ulcer is having multiple beads like appearance on the edges. So the edges may be beaded. Induration of the base is present but is less than that of epithelioma. You can see how the ulcer has eroded into the lip musculature as well as into the bones. It has eroded into the cartilage, it has eroded into the septum of the nose, and it has eroded into the bones. The nodule. Second commonest mode of presentation next to ulceration. It looks like a nodule with a pearly color. Cystic, raised circumscribed cystic lesion. Field fire type. Also called as bushfire type. Do you know what is meant by field fire or forest fire? What do you know? Sorry. There will be fire engulfing the forest and the fire is spreading at one end. So depending upon the direction of blow of the wind, the fire will be spreading in the forest. And as the fire spreads, it leaves the first area. Initially where it has started, it leaves that area, then goes to the second area, next goes to third adjacent area, like that. So the first area, then it will be left behind with burnt trees and burnt plants. So here also you can see here the ulcer is spreading fast here towards temporal region. It has initially started here. So it is looking as if it is burnt out here. So there will be scarring here and there is wild spreading lesion here. So this type is called field fire type or bushfire type. It is unusual. It is a superficial spread, heals at one edge and spreads at another edge. Then pigment type, pearly black or brown nodule, difficult to differentiate from malignant melanoma. Investigations, biopsy, microscopic appearance, masses of darkly staining cells with a characteristic arrangement, outer palisade layer of columnar cells surrounding a central mass of polyhedral cells. Cystic areas may be seen. X-ray of the part involved, that means face or the skull. Treatment, surgery, radiotherapy, local chemotherapy. Surgery, indications, doubtful diagnosis, recurrence after radiation, ulcer over or near cartilages of nose or ear, doubtful diagnosis. If there is a small lesion is there, a small nodule. So you can do a excision biopsy because you can remove the whole lesion. That is excision. That also helps you for making the diagnosis. So instead of taking a punch biopsy for a small lesion, you do with 1 or 2 centimeters margin. So that lesion can be Excised lesion can be subjected for biopsy, and the biopsy confirms the diagnosis. If the biopsy shows that it is basal cell carcinoma and margins are completely free from tumor cells, then that is the treatment for that. Then some people they prefer radiation. After radiation, if the lesion recurs, you have to go for surgery. Then ulcer over or near cartilages of nose or ear. The nose and ear have cartilages. These cartilages are very sensitive for radiation. When radiation is given, there will be radiation necrosis of the cartilages. So there will be destruction of nasal cartilage leading to deformity. So those areas you prefer to do surgery. Method of surgery: wide excision with 0.5 to 2 centimeter clearance followed by repair by flaps. Why not by skin grafting? Because you are going to remove a deep part of the tissue. When the bones are exposed or cavity is exposed, you have to go for repair by flaps. So that's why you prefer the flap repair. Number two, these lesions appear mostly on the face. When you do split thickness skin grafting, that leaves an ugly grafted area. Because that grafted area contracts, it will not have the same texture of skin as the surrounding skin. So when you do a full thickness graft or flap repair, then there will be good texture. So you always prefer for the local flap repair. In some large lesions where both cavities are involved, you have to go for a complicated flap repairs by either pectoralis major, myocutaneous flap, or other flaps. Mohs excision. What is this Mohs excision? On face with aesthetic value, excision margins can be minimized by this technique. So the person comes to you with a 1 centimeter lesion. If you are going to take about 2 centimeter margin all around it, so it will become ultimately a 5 centimeter defect will be there. So you have to do a large skin flap has to be put there. So ultimately the patient is going to get a large scar on the face. To avoid that, if you can limit the margins of excision, then you can have a better cosmetic value. So this is done with the help of this particular procedure called Mohs excision. How you do this? Serial excision in small increments with immediate histopathological examination to ensure complete tumor removal, limiting the resection to only tumor-involved areas and sparing the normal healthy surrounding tissues. For example, this is the face. There is a lesion of this much size. Now what you do is just to take 0.5 centimeter margin or even less than that. Just with the help of a microscope, you remove the lesion along with surroundings as little of normal skin as possible. That much only remove it. Then immediately you send the specimen for frozen section biopsy. So frozen section biopsy, they will see the specimen, confirm the diagnosis, and they will they will study the edge. How the edge is there. You have removed the specimen and sent it. So they study the edge at multiple places and see if the edge contains tumor cells or not. If there are no tumor cells, both laterally and even depth-wise also, then they will send the report that tumor margins or excised specimen margins are completely tumor-free. Then you can stop the excision there. If the pathologist gives a report that at 2 o'clock position, tumor cells are positive. What does it mean? Again, patient needs excision. So you again excise another 0.5 centimeters or 0.2 centimeters of the skin margin here and send it for again for frozen section biopsy. The biopsy report comes that still the excisor margins have tumor cells. Then again do another 0.2 centimeter margin excision. So you do it serial excisions in small increments till the biopsy report comes as negative for tumor cells. That means whatever that is needed, that much only you excise, because it is phase. Every decimal point of skin is essential here for cosmesis, only for cosmesis, not for any functional purpose. It is time consuming and results are equal to traditional excision. Radiation, old people who are unfit for surgery, extensive lesions. So a very large lesion is there over the face. So its removal may involve removal of half of the face. So in that case, what you do is you just give radiation. Local chemotherapy were small superficial lesions. It is done with local application of 5-fluorouracil cream. Prognosis, as it is a locally invasive tumor, prognosis is excellent after surgery or radiotherapy. Because there is no lymph nodal involvement, there is no distant blood spread. So it is only confined to the region. It is a locally invalidating lesion. However, patients should be followed up regularly for recurrence and appearance of tumors elsewhere. Then high-risk cancers. When the tumor is more than 2 centimeters, if it is present near the eye, nose, or ear, ulcer with ill-defined margins, recurrent tumors, ulcers occurring in immunosuppressive patients, these carry high risk. Any doubts, please? Any doubts, please, regarding basal carcinoma? This is also important topic. This is frequently given as a short notes as well as clinicals. It will be given. Okay, we'll go to the next topic, that is the malignant melanoma. It arises from epidermal melanocytes. Incidence, 3% of all malignant tumors. Geographical highest incidence in Queensland, Australia. Less common in black skin races, more common in Caucasians. Males are commonly affected. Is more than 30 years. It is unknown before puberty. If it occurs before puberty, it is usually from a giant congenital pigmented nevus. The site of occurrence, most commonly from the skin, any site on the body. In females, commonest site is lower part of the leg. In males, front or back of the trunk. In African Negroes, it occurs commonly on the sole of the foot. Even in Indians also, we see number of cases on sole of the foot. Then it can also arise from the mucosal surfaces of the anorectum, the pharynx, the paranasal sinuses, genital tract. Then ocular, that is choroid plexus, and iris, because they have the melanin pigment or melanocytes. Etiology, increased exposure to sunlight. So all these carcinomas of the skin, they are mainly due to continued and prolonged exposure to sunlight. Decreasing ozone layer in the atmosphere contributes to this cause. Trauma, supposed to be due to trauma, because many of the patients, they will say the trauma has caused the lesion. Because it is a painless lesion, when trauma occurs, they will focus their attention to that particular region. Then they will be able to locate the lesion, and they may think that it is because of trauma. So trauma has only made them to direct their attention to that lesion. Repeated trauma of a mole on the beard in males due to repeated shaving, or mole on pressure-bearing areas may become malignant. But this factor has not been well established or substantiated. Risk factors for developing melanoma: geroderma pigmentosum, family history of melanoma with dysplastic nevus, past history of melanoma, high total number of nevi, dysplastic nevus. Dysplastic nevus means it is irregular proliferation of atypical melanocytes in the basal layer of the epidermis. It has variegated pigmentation with irregular borders and measures more than 5 millimeters. Then in immune-compromised patients, like HIV immunosuppressive therapy patients, giant congenital pigmented nevus, 5 to 7% of these nevi, they develop into melanoma. History of sunburn in childhood. Spread of melanoma. Lateral spread precedes dermal invasion. Lateral spread means if the lesion is spreading like this, horizontally, it is lateral spread or horizontal spread. Vertical spread means spread into the depth-wise. It starts from the basal cell layer, then it goes into the dermis, then it goes into the subcutaneous tissues, then it goes into the fascia, muscle, and bone. That is vertical spread. So lateral spread means only on the sides. So lateral spread precedes dermal invasion. So microscopically, the level of invasion means deeper invasion, is estimated for prognosis. Level 1, it is intraepidermal. Level 2, up to the papillary dermis. Level 3, reticular dermis. Up to the interface of papillary and reticular dermis. Level 4 is up to the reticular dermis. Level 5 is subcutaneous tissues. Then there is one more method, of measuring the depth of infiltration, that is Breslow's thickness. The vertical thickness of the lesion is measured in millimeters after removal of the tumor to evaluate the prognosis. So the prognosis is dependent upon the vertical spread. If it spreads more deep, it is more dangerous. If it spreads horizontally or laterally, it is less dangerous. The thickness indicates the prognosis. So Breslow's thickness means you measure the thickness after removal of the lesion. Less than 0.76 millimeters, it is low risk. Between 0.76 to 1.5 millimeters is moderate risk, and more than 1.5 millimeters is high risk. Lymphatic spread. So the modes of spread being, number one, lateral invasion, dermal invasion. Number two, lymphatic spread. Lymphatic spread is by permeation as well as by embolization. What do you understand by spread by lymphatic permeation? What do you understand by lymphatic permeation? Then what is lymphatic embolization? This is also only through lymph only. So what is the difference between permeation and embolization? Yes, permeation is proliferation along the lymphatic vessel wall or lymphatic capillary. That is permeation. Embolization means a group of malignant cells, they float in the lymph, in the lymphatic vessel, and they pass to the lymph node and they cause metastasis there. So why should you know about this point, that it spreads by permeation? What is the importance of this permeation? What is the clinical significance of this permeation? Why should you know this point at all? Does it have any significance? Metastasis means yes, either by embolization or by permeation there will be metastasis. Very good, Santi. You said correct answer. It produces satellite nodules. Satellite nodules. Very good. Just I will show you here. This is the forearm. A patient developed a melanoma here. If the tumor cells spread by lymphatic emboli, then you will find the masses present in the axilla as lymph nodal masses. But these tumor cells, they spread by permeation also. Because they spread by permeation, so you can see here, there is one tumor nodule. There is one tumor nodule. That means this is a lymphatic vessel. So the tumor is passing along is migrating or proliferating by the wall of the lymphatic vessel. So here and there, in between, it forms deposits. These are called as the satellite nodules or in-transit nodules. In-transit nodules. Here you can see this is the main lesion. This fellow has developed a lymph node here. And you can see there are 2 or 3 nodules here. And there are again 2 or 3 or 4 nodules here. So all these are satellite nodules. By permeation, it produces satellite nodules and in-transit deposits between the primary lesion and the metastatic nodes. By lymphatic embolism, it produces secondary metastasis in the lymph nodes. So you can see here, the lesion is here and it has produced multiple lesions before it goes to the lymph nodes. Blood spread occurs to distant organs, to lungs, liver, brain, skin, and rarely bone. Secondaries are usually black in color. Extensive visceral involvement may cause melanuria. That means the patient may pass the melanin pigment in the urine. Clinical features. It may start in a pre-existing mole or de novo. De novo means there will not be any history of pre-existing mole. The lesion starts just like that. Or it may develop over a pre-existing mole. About 10 to 20% of melanomas, they develop in long-standing benign moles. So a mole, when do you say it is malignant? Whenever its color changes or color becomes deepened, size is more than 6 millimeters, change in the outline, surface becomes nodular or ulcerated, and surroundings. So whenever there is change in color, size, outline, surface, and surroundings, then you suspect malignant transformation in a mole. Whenever there is itching, bleeding, increased blood supply as demonstrated by color Doppler scanning, you suspect malignancy. So clinically, it presents like a pigmented lesion with the following features: A, B, C, D, E. Asymmetry, border irregularity, color variegation. That means you can see the color. It is not uniformly black. At some places it is light colored, in some places dark colored. So it is variegated. Diameter more than 6 millimeters, elevation. So when these findings are there, you must strongly suspect malignancy for a pigmented lesion. Lymph nodal metastasis in blood spread may be seen. It may present as one of the following types. So the clinical types of malignant melanoma. So before I go to this one, Santi has a doubt. I will answer that doubt first. How to differentiate clinically between satellite nodules and lymph nodes? For example, a patient is, I have shown you a forearm lesion. And by the side of the lesion, there are multiple nodules. I said they are satellite nodules. Why I said satellite nodules? Because there are no lymph nodes there. The lymphatic drainage of the upper limb is into the axilla. So there are no lymph nodes anywhere in between. If a mass is there in the axilla, you call it as only lymph nodal metastasis. You don't say it is satellite nodule. If you see a black pigmented nodule in between the primary and axilla, then you call it as satellite nodules. So lymphnodal metastasis, whenever you see a oval or a spherical or a round mass in the axilla or inguinal region or popliteal fossa or in the neck, you say it is lymph node. Or say in case of second case, that is near mandible. You know the presence of lymph nodes. The lymph nodes are present in certain groups in the neck. In the face, they are there only along the facial artery and along in the periparotid region and preauricular region. In other places, it is not there. So if it is a black pigmented nodule in the skin, it is satellite nodule. If it is a subcutaneous mass which is not pigmented, it is a lymph nodal mass. The lymph nodes masses will always be subcutaneous. Satellite nodules will always be intracutaneous. Because they are intracutaneous, you will appreciate the pigment coloration. The lymph nodes, though they are discolored with black pigment, but because they are deep in the subcutaneous tissues, their color will not be obvious because there is overlaying normal skin. Okay. The clinical types of melanoma. Superficial spreading melanoma. It is the most common type. So name itself tells superficial spreading. So instead of deeper penetration, it has more predilection for lateral spread. It's more commonly arises in the pre-existing mole. Pathology. Intraepidermal lateral extension of melanocytes occur. So there will be intraepidermal extension, not in the dermis, in the intraepidermal lesion. May occur anywhere on the body. The second variety is called the nodular variety. Pathology. Radial growth is absent. Radial growth means lateral growth is absent. These nodular lesions, they have a predilection to spread depth-wise. Appears de novo. Presents like a raised polypoidal mass and may be ulcerated. Occurs in middle age. Most malignant. Usually occurs on the trunk, head, or neck. Some are amelanotic. What do you understand by meaning amelanotic? That means they are not pigmented. They just present like nodules. So when you find a amelanotic nodule on the face, what is your differential diagnosis? If it presents like a amelanotic nodule, no, it is not sebaceous. Sebaceous will be soft in consistency, but a nodule will be firm in consistency. Whenever it presents like a nodule on the face, which is growing in size, you must differentiate it from not epithelioma, from basal cell carcinoma. Just now we have seen basal cell carcinoma can present like a nodule, like a pigmented lesion, like a cyst, like a ulcer, or like a field fire. So you have to differentiate it from the basal cell carcinoma. Then the third variety is called the lentigo maligna melanoma. It is also called Hutchinson's melanotic freckle. Lentigo means small, sharply circumscribed pigmented macule, which occurs in sunburned skins and may be an associated feature of certain syndromes like Pew-Jagger syndrome. What is Pew-Jagger syndrome? What is Pew-Jagger syndrome? Already we learnt about this. It is a syndrome. You must tell at least two diseases must be there combined. Polyps of the intestine, agreed. Next, very good. Pigmented lips, very good. So there will be oral pigmentation, not only lips. There may be pigmentation over the palate, over the oral cavity. That's very good. Fine. So it may be associated feature of syndromes like Pew-Jagger syndrome. Freckle. An area of skin that contains normal number of melanocytes with abnormally large number of melanin granules. That is called the freckle. Pathology, solar damage, atrophic epidermis with radial growth of melanoma. So this is also like superficial spreading melanoma. It spreads laterally. It occurs on sun-exposed areas of old people. So you can see the superficial spreading nature. It is least malignant. Irregular brown flat macule growing slowly with thickening and discrete nodules on the surface. So you will see a flat growing lesion which is pigmented, and here and there you will find nodules. So this is the Hutchinson's melanotic freckle or lentigo maligna melanoma. It is least malignant because it confines itself to the only to the superficial layers of the epidermis. Freckle means an area of skin that contains normal number of melanocytes with abnormally large number of melanin granules. So this is a microscopic description of the skin. There are normal number of melanocytes, but the melanin granules in the melanocytes, they are abnormally large. Then you call it as the freckle. So it is a histological feature of when you study this lesion, you will find the normal looking melanocytes, but they have abnormally large number of melanin granules. And fourth variety is the acral lentiginous melanoma. Here there is radial growth with reactive epithelial hyperplasia. So you can see here there is melanin growth is there laterally. As a reactive thing, there is epithelial hyperplasia over it. So the epidermal cells, they react and then they form a layer over this. It is least common. In Japan it is the commonest. Occurs on hairless skin, that is nails, palms, and soles. It is highly malignant. It usually occurs on the soles. Differential diagnosis, it should be differentiated from melanonychia, that is black streak under the nail in a dark-skinned person. Nail fold is uninvolved in this case. So in some black skin like Negroes, you will see black pigmentation of the nail bed. In acral lentiginous melanoma also, there will be black pigmentation of the nail. So in the melanoma, there will be pigmentation of the nail fold also, but in melanonychia, there will be only pigmentation of the nail bed. Nail fold is not involved. Amelanotic melanoma. It is rare. It is a pink nodule with pigmentation at the base. It is highly malignant. Stages. So these are the clinical types. So there are about 5 clinical types. So it can be of any one of these clinical types. Then stages, depending upon the infiltration and metastatic spread. Stage 1, primary tumor only. Stage 2A with the satellite nodules. Stage 2B, regional lymph nodal metastasis. Stage 3, visceral metastasis or lymph nodes other than regional lymph nodes. This is stage 3. Differential diagnosis. All pigmented lesions has to be differentiated. So what are the pigment lesions of the skin? Apart from melanoma, there are few benign pigmented lesions and few malignant pigmented lesions. So the benign pigmented lesions, which are pigmented, you tell me some pigmented benign lesions. Good, name why. Next. Okay, wart means which wart? There are 2 types of warts. Squamous cell papilloma and basal cell papilloma. Which wart? Seborrheic wart. Very good. That is called basal cell papilloma, also called seborrheic wart. Next. What are the other lesions which are pigmented? Benign pigmented nevus, pyogenic granuloma, seborrheic wart, hemangioma. So these are the pigmented lesions, benign. Then you are differentiated from other malignant pigmented lesions. Tell me one malignant pigmented lesion other than melanoma. Wonderful. It is basal cell carcinoma. Very good. So pigmented basal cell carcinoma. There is one more condition that's called sarcoidosis. Sorry, Kaposi sarcoma. Kaposi sarcoma also produces malignant, pigmented lesion. So these are the examples. This is benign nevus, granuloma pyogenicum, seborrheic wart, strawberry hemangioma, basal cell carcinoma, and this is Kaposi sarcoma. Investigation, biopsy. Okay. ABC wants to have acral lentiginous melanoma explanation once more. Acral lentiginous melanoma, there is lateral spread with reactive epithelial hyperplasia. So the melanoma will be spreading laterally and overlaying epidermal layers, they react with hyperplasia. That is why there will be thickening of skin over the melanoma. This is least common. It occurs on hairless skin like nails, palms, and soles of the feet. It is highly malignant lesion. It has to be differentiated from because it occurs in nails. In black-skinned individuals, the nails also will be there. So how to differentiate? When it is due to melanonychia, that means black streak on the nail of a dark-skinned person. The pigmentation is confined to only to the nail. In melanoma of the nail, there will be involvement of the nail fold also. So that is about acral lentiginous melanoma. Investigation, biopsy. Suspicious moles should be subjected for excision biopsy with 2 millimeters margin. Incisional biopsy is advised for large macular nevi on the face. So usually you should not go for small incision biopsy of the lesion. You must remove the whole lesion. But if it is a very large lesion is there, then you can do only incisional biopsy, because if you want to remove the large lesion means it will leave behind a large defect, and ultimately it may turn out to be only a simple benign mole. But on incision biopsy, some studies have shown that there will be malignant transformation of the mole. Ultrasound scan for abdominal metastasis, X-ray chest for secondaries in the lung. Radiotherapy and chemotherapy has no role for the stage 1 lesions. Surgery, wide excision of the lesion with 2 to 3 centimeters clearance. Here you go for more clearance depending upon the thickness of the tumor. Deep fascia is not included in the specimen, so you leave behind the deep fascia. So depending upon the thickness of the lesion, you go for 1 centimeter to 3 centimeters margin. And the area is repaired by grafting. Isolated lymph perfusion with melphalan is used in some centers for extremity tumors with poor prognosis. Lymph nodal management, uninvolved lymph nodes, controversial issue. That means if lymph nodes are not involved, what to do? Some suggest they do prophylactic block dissection. Some they do not do it. So prophylactic block dissection is not done if melanoma is of low virulence, less than 1 millimeter in diameter thickness, or belongs to class 1 or 2 level. 2 level means involvement of the only papillary dermis. If primary is in within 5 centimeters of the lymph nodal area, block dissection is in continuity is advised. That means if the lesion is there at the inguinal region, for example, then you do inguinal lymph nodes also are excised along with the lesion. You can do sentinel node biopsy and you can confirm whether the sentinel node has positive node or not. If it has a positive node, you can do excision or you can do block dissection of the lymph nodes. So if the lymph nodes are not involved, prophylactic blood dissection usually is not done, but it's preferable to do a sentinel node biopsy. What do you understand by sentinel node biopsy? Sentinel node biopsy is one of the frequently given questions in the theory examination. And examiners also will ask you now and then, what is sentinel node biopsy? What is sentinel node biopsy? What is the meaning of sentinel? What is the literal meaning of sentinel? Sentinel means no, all of you are wrong. Sentinel means God. Guard, God. So, for example, these are the lymph nodes in the inguinal region, let us suppose. So, there are about some 15 or 20 nodes here. There is a lesion in the foot here. So, just at the base of the toes, there is a melanomatous lesion. Or some lesion is there. The lymphatics will go like this to this lymph node, let us suppose, to this lymph node. This lymph node is called the sentinel node. Why it is called sentinel? Because this, out of these 10 nodes or 20 nodes, this particular single node is guarding this particular area. This particular area is being guarded by this. What is the function of lymph nodes? The function of lymph nodes is guarding. If any tumor or if any inflammatory cells or infect bacteria microbes, they enter into the lymphatics, they will filter them, they will stop them there without going upwards. So in one way, they are stopping the growth of the tumor, but they are being subjected to the disease itself in this process. So sentinel means it is a guard. So that particular, out of these 10 nodes, that is the one which guards this particular area. So sentinel node biopsy means you pick up the node, the first lymph node, which drains that particular area. So if melanoma is there at the base of the toes, you inject the isosulfan blue dye there. After 45 minutes, you will find the dye being concentrated in the one lymph node. So you make an incision about the inguinal lesion and you see the stained lymph node, you remove that lymph node, send it for biopsy. The biopsy report comes whether positive or negative. If it is positive, then remove all the lymph nodes. If it is negative, then don't touch the inguinal region. What will happen if you just remove all the lymph nodes? Anyway, you have made an incision there. Why can't you remove all the lymph nodes, the fascia, the fat, the tissues there? Why you don't remove? You remove it only whenever the sentinel node biopsy is positive. What will happen if you remove for every case? Are there any side effects of this block dissection? Yes, lymphedema. Lymphedema is one of the most troublesome, very troublesome side effect after this block dissection. I have about 2 or 3 patients, so they bother me a lot. So for life, they must follow certain precautions. They must keep the limb elevated while they are sleeping. When they are walking, they should always wear elastic bandages. In spite of that, they will get now and then infections, oozing of lymph, lymphorrhagia, and other complications. So it gives a hell of trouble to the patient. That is why you don't do block dissection just like that for every case of melanoma. You do sentinel node biopsy, the sentinel node biopsy is positive, then you go and do the block dissection. Okay, this is the method of doing sentinel node biopsy. Sentinel node biopsy is also done for the breast, colon, and penile cancers. Then stage 2A. What is stage 2A? Presence of satellite nodules. Whenever there are satellite nodules, we call it as stage 2A. If the disease load is not large, local treatment with the scalpel, laser, or cryoprobe is done. So those satellite nodules are scraped away. Just if there are few are there. If the disease load is large, there are multiple satellite nodules are there over the limb, then you go for the isolated limb perfusion. What is this what is this isolated limb perfusion? You apply a tourniquet just below the groin. Make an incision to expose the femoral artery and femoral vein. Then what you do is you inject the you okay, you take the blood from the vein, you collect it into a bag, and to the bag you add chemotherapeutic drugs, because usual chemotherapy is not effective for melanoma. That is why you give high dose of chemotherapy drugs are added to this bottle, and this bottle is connected again to the femoral vein, and there is a pump here or a motor there. So the motor will be pumping the blood from this into the vein, into the artery. So blood is collected from the vein and is pumped into the artery, femoral artery. So what will happen? This chemotherapy mixed concentrated drug will be going into the femoral artery and getting infused over the whole of the limb. The tourniquet is applied here so that this chemotherapy drug will not flow back into the general circulation. So the chemotherapy drug will go into the artery, it perfuses the whole limb and returns back again through the vein and again circulates. So they will do it for about 25 to 30 minutes. So with this, they will be the whole limb gets perfused with high dose of chemotherapeutic agent, and that will kill the tumor cells. Stage 2B, if nodes are suspiciously enlarged, FNAC is done to confirm the diagnosis. If positive, do block dissection. Stage 3, that means visceral metastasis. Then there is no other alternative than going for chemotherapy with interferon or Vinca alkaloids, immunotherapy with interleukin 2. Recurrent melanoma, surgery if isolated, isolation perfusion with high dose cytotoxic agents for multiple or in-transit recurrences. Prognosis, low risk group. So for prognosis, the melanoma patients are divided into two groups, low risk and high risk group. Low risk group means breast loss thickness is 0.76 millimeters or less, or clocks 1 and 2. Moderate risk means bristles thickness 0.76 to 1.5 millimeters, or clocks level 3 and level 4. High risk group means bristles thickness more than 1.5 millimeters, or clocks level 5. Bristles thickness is one of the frequently given short notes question in the theory examination. Survival rate for 10 years, lesions of low risk 87%, high risk group 30%. So this is about the epidermal malignancies. So the epidermal malignancies being squamous cell carcinoma, basal cell carcinoma, malignant melanoma, also called as simple melanoma. And there are lesions like carcinoma in situ, that is Bowman's disease and Paget's disease. So are there any doubts for you in these three topics? Okay, if you have no doubts, we'll go to the next topic, that is the dermal malignancies. So the dermis of the skin, they also can have malignant lesions. These are rare. These being dermatofibrosarcoma protuberans, Kaposi's sarcoma, mycosis fungoides, cutaneous hemangioendothelial sarcoma, dermatofibrosarcoma protuberans, locally malignant tumor arising from dermal fibroblasts. Clinical features: it is a solid tumor from skin. What are the other solid tumors from the skin, which we have learned already? What are the other solid tumors of the skin? Yesterday we learned solid tumors, the sweat gland tumors, the sebaceous gland benign tumors, the hair follicle cell tumors. So these are all the solid tumors. So this dermatofibrosarcoma protuberans also manifests like the solid tumors of the skin. Treatment: wide excision with a margin of 3 centimeters, because this tumor has a tendency for recurrence, so it should be removed with wide margin. Complications: recurrence if excision margins are inadequate. Then angiosarcoma, cutaneous angiosarcoma arises from endothelial cells. Rare, it is highly malignant tumor. Kaposi's sarcoma, it is a low-grade soft tissue malignant tumor. It arises from vascular endothelial cells. In HIV patient, it is due to infection by HV8, that is human herpes virus 8 infection. It is seen in immunocompromised patients such as kidney transplant patients. These are all the lesions you can see. They will be reddish or brownish pigmented patches in the skin. That is Kaposi's sarcoma. Painless, slow-growing reddish-brown nodules, usually on the leg or foot, which may ulcerate. In 10% of the cases, mucosa of the G8 may be involved. In HIV patients, it manifests as skin, mucosal, and lymphadenoid form with aggressive presentation. Differential diagnosis: granuloma pyogenicum. Treatment: localized form radiotherapy, generalized form chemotherapy. Then Other dermal malignant lesion being the mycosis fungoides. It is a form of primary cutaneous malignant lymphoma. It is a type of lymphoma. You will confuse it for fungoids means you will think that it is a deep fungal infection. Mycosis means it is not like that. It is not a fungal infection. It manifests as cutaneous ulceration and later as lymph nodal enlargement associated with hepatosplenomegaly. Bone marrow and other organs may also be involved. Investigation biopsy, treatment radiotherapy or chemotherapy. So with this, we are going to complete the skin lesions. Now we'll discuss about the soft tissue lesions. The swellings may arise from fat, fascia, muscles, tendon, bursa, nerves, blood vessels. These tumors are graded by Trojan system, done on tumor differentiation, mitotic count, and tumor necrosis. Staging is done by TNM staging. General features of soft tissue tumors. Soft tissue swellings are common and most are benign. Future suggesting malignancy. Pain, swellings more than 5 centimeters or swellings increasing in size. Swelling deep to the deep fascia. History of recurrence after surgery. Each of these factors carry a risk of 25%. Investigations, MRI scan of the area and biopsy of the lesion. In malignant lesions, X-ray of the chest and ultrasound scan of the abdomen to be taken for secondaries. Soft tissue benign tumors, lipoma. Pathology, it is a benign tumor of fat cells of adult type. It may be single or multiple. The multiple lipomata have some relationship to multiple neurofibromatosis. Both may occur in same patient, but both are hematomas. So lipoma also can be a hematoma. Hematoma means a developmental malformation. Types of lipoma: encapsulated is the commonest type. Diffuse type means without capsule it will be there. Diffuse lipoma is rare, occurs in subcutaneous tissues of the neck as diffuse fatty swelling. This is also called as the Madelung's neck or benign symmetric lipomatosis. Sometimes it extends into the mediastinum. So because whenever the neck is there, lower body is not palpable means you must go for MRI of the chest. It's more common in males and alcoholics. Benign and is removed if unsightly. Encapsulated lipoma is more common. It may be admixed with other connective tissue structures. Depending upon other constraints, it is of the following types: fibrolipoma, nevolipoma, neurolipoma. So if it has a lot of fibrous tissue, we call this as fibrolipoma. If it has vascularity, it is called nevolipoma. If it is nerve fibers, it is called neurolipoma. Why is it called nevolipoma, vascularity? Nevus means a birthmark. So why is it called nevolipoma? Yes, because of the pigmentation. Because of the vascularity, it will be pigmented. The lipoma grows by expansion, and the capsule is formed around the slow growing lipoma due to compression of the normal surrounding tissue. It doesn't infiltrate and doesn't spread by lymphatics or blood spread. Size is variable. It may be very small lesion of 2 centimeters or 0.5 centimeters in diameter, or it may be very huge mass, painless, slow growing swelling. It is sometimes may be very soft, then it's called pseudofluctuation may be present. It is mobile with a definite edge which slips under the finger. Surface is lobulated. Deep-seated lipoma in muscles present as a mass and cannot be differentiated from other swellings of the muscles. It may be multiple. Now you can see here the lobulation. So you can see here one lobule. There is one more lobule. There is one more lobule. So it is the appearance of the lobulation. This is a method of demonstrating slipping edge. This is the edge. You keep your finger over the edge. Then it gets displaced because of the mobility, that's all. Because of the mobility, the mass moves forwards or slips away from your finger. So sometimes it may be multiple. So this is the lobular appearance. So you can see here lobules. So when you remove this mass, you can see the lobular appearance like this. Why these lobules are there? The lobules are present because of the fibrous septa. So there are multiple fibrous septa which makes this fat mass into multiple lobules. To demonstrate the lobulation, what you should do is you stretch the skin at one edge. Then lobulation will be more perfectly seen. Whenever the lipoma is there within the muscles, you must always differentiate it from a muscle swelling, a muscle mass. A muscle mass means it may be a fibrosarcoma of the muscle. Consistency varies depending upon the other constituents. If it is pure lipoma, it will be soft in consistency. If it is have admixture of fibrous tissue, it will be firm in consistency. Nevolipoma will be having superficial telangiectasia. It should be differentiated from sarcoma because of the enlarged vessels for the surface. The neurolipoma is tender, firm swelling. The features also vary depending upon the site of the lipoma. Lipoma can occur anywhere in the body, hence it is called as the universal tumor or ubiquitous mass, ubiquitous tumor. It can be subcutaneous, which is more common. So all the features that just now described are present for the subcutaneous lipoma. It may become pedunculated. So you can see this pedunculated lipoma. So here is the one more pedunculated lipoma. This is a large pedunculated mass. So actually this mass is there in the ischiocrectal fossa. So there is lipoma of the ischiocrectal fossa which has extended into the deep perineal pouch, and from there it has bulged out and manifesting like this mass, like a lobulation mass. But in fact, this mass was there deep into the deep perineal pouch as well as into the ischiorrectal fossa. So subfacial lipoma, low cannot be demonstrated. Intramuscular presents as a mass in the muscles. It should be differentiated from fibrosarcoma, parasitic cysts, and abscess in the muscles. Subsynovial, it has to be differentiated from cyst around the joint or the bursa. Other sites where lipoma can occur are intra-articular, paraosteal, submucous, extradural, retroperitoneal, and subserous. The clinical presentation in these sites is due to the mass effects of the lesion. Submucous lipoma in the intestines, how it manifests? Tell me. Submucous lipoma in the small bowel, how it manifests? It's very good. It manifests as intussusception. Very good. Multiple lipomata is not uncommon. Small to moderate in size, may be painful because of neurolipomatosis. So when it is painful and multiple, then we say it is there comes disease. Complications of lipoma, there can be myxomatous degeneration, saponification and calcification, and there may be sarcomatous change, of course rare. Large lipomata of the thigh and retroperitoneum are prone to become malignant. Some suggest these sarcomas occur de novo. You can see this is a lipoma removed from the retroperitoneal region. So usually these lipomata are sarcomatous. For deep-seated lesions, you must take MRL scan, FNAC or true cut biopsy. So FNAC shows these fatty masses that are there in between the muscles. Differential diagnosis, you are differentiated from fat pads in supraclavicular areas of cretins or in obese individuals. Sometimes you see large fat pads in the supraclavicular fossa. Sarcomatous change means becoming malignant. Lipoma is a benign tumor of the adipose tissue. Sarcomatous change means it develops malignant transformation. Not only gains vascularity, it spreads by blood, it infiltrates the local tissues. Then also you have to differentiate it from the fat overgrowth in obese individuals. From chronic abscess, cysticercosis from multiple lipomatosis, then hemangioma. So these are the things you have to consider in differential diagnosis. For example, there is a lipoma in the parotid region, parotid gland. So it will be lobular, it will be soft in consistency. So hemangioma also will have the same features. Treatment, surgery, indications, cosmetic reasons, for the complaint of pain, large size causing discomfort, suspicion of malignancy, procedure, sorry, procedure is intracapsular excision, that is called enucleation. All all finger-like processes should be removed. And there is a recent technique that's called the liposuction. So in this liposuction, what you do is you make a small incision of 10 millimeters or 1 centimeter. Through that, you pass a long cannula with multiple holes. You connect this cannula to a suction apparatus. So switch on the suction apparatus, and while you move this cannula in the subcutaneous plane, all the fat will be scraped off from the subcutaneous area and that gets sucked in. So you can remove large masses of fat with this liposuction. Actually, this liposuction is used for shaping the body in obese individuals where there are a lot of fat pads like in the flanks, buttocks, thighs, so they can be made slim. Of course, this is not to reduce obesity but to reduce fat masses. So this is usually done by the plastic surgery people. So this is about the benign tumors of the fat, then the benign tumors of the now. Any doubts? Lipoma cases are usually given as a in clinicals, very commonly given for the students, lipomas. Okay. Then now benign tumors. Classification: tumors of the nerve cells, tumors of the nerve sheath. Already I told you the nerves have nerve cells and they have axons, they have dendrites. The axons, they are provided with a sheath. So the tumors can arise from the nerve cell or they can be from the nerve sheath. Tumors from nerve cells, there is ganglioneuroma, pheochromocytoma. Tumors of nerve sheath, benign, schwannoma, also called as the neurilemoma, then neurofibroma, myelinic neuroma. Ganglioneuroma, it arises from ganglion cells of the sympathetic chain. Already we have studied about the sympathetic chain. It is situated in the retroperitoneum as well as in the posterior mediastinum as a paravertebral region. How many ganglia are there in the thoracic region? Of course, not related to ganglioneuroma. Just I want to assess you how far you have followed sympathetic system or how far you remember. How many ganglia are there in the thoracic region in the paravertebral ganglia? Only two have answered. What about others? Okay, you are right. Both ABC and Manognia both are right. There are 11 ganglia. Okay. So ganglioneuroma arises from ganglion cells of the sympathetic chain. So sympathetic chain is there in the cervical region. There are 3 ganglia. Thoracic region, there are 11 ganglia. Lumbar region, there are 4 ganglia. So it can occur in any of these regions. So it may be in the retroperitoneum, posterior mediastinum, or in the neck. And the ganglion cells of the sympathetic chain are also there in the adrenal medulla. So the ganglion neuroma can occur there also. So this is the ganglionated chain. Then nerve sheath tumors. So this is the axon, nerve fiber. This nerve fiber is surrounded by myelin sheath. And again, this myelin sheath is enclosed by the Schwann cell or neurolemmal cell. And this is surrounded by the fibrous tissue, that is the endoneurium. Already we have discussed about the endoneurium. Schwannoma, also called as the neurolemmoma. So this neurolemmal cell will become malignant. It arises from the neurolemmal cells. It is an encapsulated benign tumor. Tumor arises eccentrically from the nerve, and hence pressure effects on the nerve are not seen. When it arises from 8th cranial nerve, it is called the acoustic neuroma. Presents as a form, lobulated or spherical mass, mobile in one axis only. Mobile perpendicular to the nerve and restricted along the nerve fiber. Percussion of the mass produces paresthesia along the nerve. Treatment: enucleation. As the nerve is displaced, it can be removed without damaging the nerve fiber. Myelinic neuroma, very rare, occurs when the myelinated nerve fibers of the spinal cord. Neurofibroma, it is discussed in hematoma. From which structure neurofibroma arises? From which tissue neurofibroma arises? It's very good. It arises from the endoneurium. Very good. Soft tissue malignant tumors. These arise from mesenchymal tissues. That is why they are called as sarcomas. All malignant tumors arising from the epithelium or epidermis are called the carcinomas. All the malignant tumors arising from the mesenchymal tissues are called as the sarcomas. So the soft tissue malignant tumors can arise from mesenchymal tissues like fibrous tissue, areolar tissue, deep fascia, like that. They can also arise from neural tissue, from the nerve cells. It is called the neuroblastoma, malignant pheochromocytoma. From nerve fibers, it is called the malignant schwannoma and nerve sheath fibrosarcoma. Neuroblastoma. It is an embryonal tumor from undifferentiated neuroblasts. It occurs in infants and young children, arises from adrenal medulla and sympathetic chain. That means it arises from the ganglionated cells. Because the nerve cells are present only in the ganglia. Nerves represent the nerve fibers. So the cells are there only in the ganglia or in the central nervous system, in the spinal cord. The ganglia are there in the peripherally, and the ganglia manifest as paravertebral ganglia and the celiac plexus, superior mesenteric plexus, inferior mesenteric plexus, hypogastric plexus. So this plexus is nothing but the ganglion cells and then nerve fibers. And also these ganglionated cells are present in the end organs like the muscles and submucosa, and the mesenteric plexus and myenteric plexus. They also have the ganglia. So these ganglia are the the ganglia of the parasympathetic system. The sympathetic system has ganglionated cells in the paravertebral ganglia, but the parasympathetic system has the ganglia in the target organs itself, like in the muscles of the smooth muscles of the small intestine. So this neuroblastoma and ganglioneuroma arises from the ganglionated cells. So the ganglion cells are present in the adrenal medulla and sympathetic chain. So these lesions can occur from them. But from the smooth muscles of the gut, they are very rare. They can also occur there, but they are very rare. They are highly malignant. They spread by bloodstream, causing bone secondaries. This is the commonest extracranial malignant solid tumor in infancy and childhood. Spontaneous remission may occur sometimes. So this is a child with a mass in the lumbar region, along with the multiple swellings on the skull bone due to the secondaries. Malignant schwannoma and neurofibrosarcoma present like a soft tissue sarcoma. Early neurological damage is seen. Soft tissue sarcomas. Sarcomas are malignant tumors arising from mesenchymal tissues. They are classified depending upon their tissue of origin. Fibrous tissue, if they develop from fibrous tissue, it is called fibrosarcoma. Adipose tissue, liposarcoma. Skeletal muscle tissue, it is called rhabdomyosarcoma. Blood vessels, it is called hemangio endothelial sarcoma or Kaposi's sarcoma. Lymph vessels, lymphangiosarcoma. Nerve fibers, neurofibrosarcoma and malignant schwannoma. Synovial tissue, synovial sarcoma. Fibrohistiocytic tissue, malignant fibrous histiocytoma. So these are all the various types of sarcoma. But usually sarcomas are all grouped under soft tissue sarcomas. So these are all the constants of soft tissue sarcoma. These are the types of soft tissue sarcomas. So all these sarcomas, they have common general features. They be occurs at an early age than carcinoma. Carcinoma usually occurs in the middle age. These occur at an early age, most common during first and second decades itself. Incident sarcomas constitute less than 1% of cancers in adults and about 7% of cancers in children. They are more common in lower extremity, rare in the head and neck. 2/3 of soft tissue sarcomas arise in the extremities. It grows rapidly. It is highly vascular. How do you know that they are highly vascular? When the tumors are highly vascular, you will see engorged veins, dilated blood vessels on the surface, and this mass feels warm to touch. If vascularity is more, where there are multiple arteries, so if the artery supply also is more, then the tumor may exhibit pulsations also. There may be areas of degeneration and hemorrhage in the mass. There is pseudo-encapsulation of the tumor, and the pseudocapsule contains tumor cells. So the tumor has a outer shell, but the shell is formed by the tumor itself. Lipoma also has a shell or a capsule, but that capsule is formed by surrounding tissue which got compressed. But in case of soft tissue mass, the outer lining it gets compressed and becomes capsule like. It looks like capsule, but it has the malignant cells. Etiology: exposure to some chemicals have shown an increased risk of carcinoma. Lymphedema: chronic lymphedema after axillary node dissection for carcinoma breast have shown high incidence of lymphangiosarcoma. Genetic: certain sarcomas are associated with some hereditary cancer syndromes, including retinoblastoma, Lee-Fraumeni syndrome, neurofibromatosis type 1, and familial adenomatous polyposis. Spread: local spread by pushing along the tissue planes. Fascia, nerve sheath, and adventitious vessels are resistant to invasion. So they just spread by pushing along the tissue planes. Carcinomas, they infiltrate. If any fascia is there, it just simply infiltrates and goes beyond that. But sarcomas, they usually cause spreading and they push the surrounding tissues and gradually they spread. Lymphatic spread: sarcomas do not spread by lymphatics. Ewing sarcoma, synovial sarcoma, rhabdomyosarcoma can spread by lymphatics. But all the other sarcomas, they spread only by blood spread. Blood spread occurs early. Lungs are the commonest site of secondary deposits. Microscopic appearance: tumors are classified as high, intermediate, or low grade depending upon cell differentiation, mitosis, and invasiveness. Grading helps for planning the treatment and for evaluating the prognosis, risk of local recurrence, metastasis, and survival. Clinical features is commonly seen in young adults. Presents as rapidly growing mass with or without pain. Its consistency may be firm, rubbery, or variable due to areas of cystic degeneration and hemorrhages. So we have already seen that sarcomas may have areas of degeneration and hemorrhage. Local warmth and enlarged veins are present over the surface of the mass due to high vascularity. Mobility depends upon the tissue of origin and infiltration. Lymph nodes are not involved in majority of the sarcomas. Differential diagnosis: lipoma. Lipoma is 100 times more common than sarcoma. Then lymphangioma, hemangioma, neurofibroma, chronic abscess, parasitic cyst, hematoma, aneurysm. So, because sarcomas are the malignant tumors arising from the soft tissues, that means they will be usually deep to the deep fascia. That means usually to the muscles or deep to the muscles. That is why any benign tumor arising in the muscles also can be mistaken for sarcomas. So the benign tumors occurring in the muscles or deep to the muscles are usually lipoma, lymphangioma, hemangioma, neurofibroma, chronic abscess, then parasitic cyst, hematoma, and aneurysms. Sorry, it is hematoma and aneurysm. Any enlarging soft tissue mass, especially if deep to the deep fascia, should be suspected as sarcoma till proved otherwise by investigations. So anything that is deep to the deep fascia, any mass, first you suspect sarcoma. Investigations: diagnostic imaging, X-ray. It is of little use in soft tissue sarcomas. It shows only soft tissue shadows. Ultrasound scan It shows cystic and solid areas, and Doppler scanning is useful to observe the relation of the vascular tissue structures to the mass. CT and MRI scan. MRI scan is better. It shows the extent of the mass, involvement of the muscle groups, relation to the vessels and nerves, and consistency of the mass with areas of degeneration or necrosis. So exact plane of the mass, from which group of the muscles the mass is arising, and what are the groups of muscles that are being involved with the mass can be evaluated better with MRI scan. So you can see here a sarcoma of the thigh region. You can see such well demarcated borders. Unlike in carcinoma, you can see well demarcated. That means they have their own capsule. Again, you can see it here. It is having lobulations also. So it is looking something like a fatty mass here, but it is a soft tissue mass. By looking at this, you can't differentiate from lipoma and soft tissue sarcoma. But you can say which plane it is there. It is there in the muscles. And you can look at the blood vessels also. In some other sections, you can see the blood vessels. How the blood vessels are there, femoral artery, is it being displaced laterally or posteriorly or superficially? You can make it out. So its relation to the vessels and nerves can be evaluated. And extent of the growth can be seen. And which muscle compartment is being involved, that can be evaluated. Here, for example, the adductor group is involved here. Here also it is the adductor group that is involved. This is, of course, a lipoma, which is situated in the quadratus femoris. That means in the extensor compartment. So the first investigation is imaging study with MRI to know the plane of the swelling and extent of the growth of the swelling and relation to the surrounding neurovascular structures. Then histopathological examination. Biopsy. Excision biopsy should not be done as accurate planning for lateral surgery is difficult. FNAC for deeper lesions. Guided aspiration is done. True cut biopsy. If FNAC report is ambiguous, true cut or true cut punch biopsy is done to study the histopathology of the tumor. Sarcoma is graded histologically into well-differentiated, intermediate, and ill-differentiated tumors. Well-differentiated tumors with limited metastatic potential are desmoid tumor, well-differentiated liposarcoma, dermatofibrosarcoma protuberans, and hemangiopericytoma. These are all the well-differentiated tumors. Then tumors with intermediate grade are myxoid liposarcoma and extracellular chondrosarcoma. Ill-differentiated tumors are angiosarcoma, clear cell sarcoma, pleomorphic and dedifferentiated liposarcoma, leiomyosarcoma, rhabdomyosarcoma, and synovial sarcoma. So don't bother about these things. Just think about only grading. Grading can be done to differentiate, to grade the tumors into differentiated, well-differentiated, intermediate differentiated, and ill-differentiated tumors. So whenever you want to do investigation of a soft tissue mass, just now we have seen a thigh mass. So if that patient comes to you, before you go for surgery, you must have the diagnosis, because your diagnosis should be established whether it's a benign tumor or a malignant tumor. If it's a benign tumor, what you do? You do just local excision, enucleation. For a malignant tumor, what you should do? You should go for wide excision. The muscle from which the swelling is arising and the compartment in which the muscles are, the tumor is there. So all these things must be removed. Now, for example, a patient comes to with a small 3 by 3 centimeters mass in the thigh muscles. You think that it is a lipoma. So, without doing any investigation, you do excision. After excision, you will see that it is not a fatty mass, it is a solid mass. So, you will send it for biopsy. Okay? So, you have removed the mass from the thigh region. Thigh region, which muscle? It may be from the rectus femoris, it may be from the vastus medialis, it may be from the vastus lateralis, or it may be from sartorius, or from vastus intermedius. You do not know. So you may be knowing. So you remove that mass and send it for biopsy. Biopsy report comes as, for example, it is soft tissue sarcoma or fiber sarcoma from the muscle. You have just done excision. So if you remove the mass only for the sake of biopsy, the biopsy report comes as sarcoma. Now what your treatment? You should do wide excision. So once you have removed something from the muscles, if you open it there, you can't find the scar there because all fleshy. You can't make out the place. So then how can you do wide excision? It is impossible for you to do wide excision. That is why excision as a for biopsy purpose is not done. You must take a small bit by true cut biopsy. Already I have shown you the true cut needle. So this is the true cut needle. So with the help of the true cut needle or with a core biopsy needle, you take a small core of tissue and send it for biopsy. Once the biopsy report comes as sarcoma, you take MRI scan. Then you study which group of muscles are involved. It is vastus medialis or vastus lateralis or rectus femoris or vastus intermedius or sartorius. So in the extensor compartment, all these 5 muscles are there. So which muscles are involved here? You evaluate by seeing MRI scan. You see the size. By that you plan excision, how much excision has to be done. So you can excise it. If you do just excision biopsy, you will not be able to identify the place where you have removed the tumor, so you cannot plan a wide excision. That is why simple excision biopsy is not advocated. So investigations being number 1, core biopsy or true cut biopsy. Number 2, imaging study by CT or MRI. MRI is preferable. Then take chest X-ray to see for secondaries in the lung, common site for metastasis, ultrasound scan of the abdomen to evaluate for secondaries in the liver. Treatment, of course, I will tell you about the treatment in tomorrow's class. So we have left with only few slides. That means tomorrow we'll have only about 15 minutes talk, my talk. Afterwards, I will show you some of the cases of the skin and soft tissue lesions. You must tell me the diagnosis, you must tell me the plan of management, etc. So please read skin and soft tissue lesions topic, and we will have good case discussion tomorrow. So come prepared. All of you should participate. Okay? That's fine. So the treatment and other parts are just only of about 10 to 15 minutes time. Afterwards, we'll have complete discussion on the cases. Some of the spotters I will show you, and I will ask you to identify those spotters. Skin and soft tissue lesions are commonly given in the clinicals. So you must be thorough with each and every case. Okay? See you. Tomorrow we'll see you at the same time. Wish you all a good night. Thank you.